Hello everyone, hope you will be fine and welcome to my channel. We have discussed our general surgery subject and we have discussed all the topics. Now we are starting our systemic surgery subject. We are having some important units that we will discuss one by one. I will try that we cover this systemic surgery subject in 4 days. The main units that we are having are breast. We will discuss breast and then the thyroid, and then we will discuss orthopedic surgery, then upper GIT, and then lower GIT, and then in the end we will discuss the urology. These are the important topics that we will be discussing. Today in this section we will study the breast and the important topics of breast. These are the introduction of breast, the fibroadenoma, the breast abscess, the mastalgia, the carcinoma of breast. So starting from the introduction of the breast, what is the introduction? What is nipple discharge and how patients refer? 7% of patients referred with breast discharge. It may be serous blood stains or colored. Now discharge from surface is eczema or Paget's disease, while discharge from single duct is maybe blood or maybe serous. Blood is from duct papilloma, duct ectasis and duct carcinoma, while serous is fibroadenosis, duct ectasia or duct carcinoma. Discharge from more than one duct, then it may be blood, may be black in color, may be purulent or may be milk. In blood, it is duct carcinoma or duct ectasia or duct papilloma, while black, that is duct ectasia. If it is purulent, then it is mastitis, and if it is milk, then it is lactation or hypothyroidism or prolactinemia. What is the treatment for the nipple discharge? We are having, first of all, we will exclude the malignancy by triple assessment. Then we will reassure the patient, and then if there is intolerable discharge, then surgery is done. What type of surgeries are done? We are having microdectomy and cone excision of the major directs. What investigations are done for the breast disease? These include history, the clinical examination, the mammography, the ultrasound, the MRI, the biopsy, and the triple assessment. Triple assessment is the combo of clinical assessment plus radiological assessment plus histological assessment. So what we have studied is, we have studied the breast introduction. That is, the first topic that we are discussing is the nipple discharge. So 7% of patients referred with breast discharge. Then we are having the types of breast discharge. It may be from surface, may be from the single duct, and may be from more than one duct. If it is from the single duct, then it is eczema or Paget disease. If it is from single duct, then it may be blood or serous, and if it is discharged from more than one duct, then it may be blood, black, purulent or milk. What are the treatment options? We will exclude the malignancy and reassure the patient, and then we will be doing the surgery if it is intolerable discharge. The surgical options are microdectomy or cone excisions of major directs. Then we will do the investigations. Investigations are history and clinical examination, mammography, ultrasound, MRI, biopsy, and triple assessment. Now coming towards the fibroadenoma. It is also known as breast mouse and it is mobile in all directions. Fibroadenoma is a type of tumor or adenoma which is mobile in all directions. We are having a scenario which says that 33 years woman come to OPD and notice lump in breast. No nipple discharge is there. On examination, right breast 3 cm lump in upper outer quadrant which is hard, non-tender, no evidence of enlarged lymph nodes. Now what is the diagnosis and confirm how we will confirm the diagnosis and what is the management. So for fibroadenoma, you should remember these points: that it is hard, there is no discharge, it is 3 cm in size, and there are no enlarged lymph nodes in the case of fibroadenoma. Okay, fibroadenoma is the most common benign tumor of the female breast. What are the clinical features? It is common in young age from the age 15 to 25 years and occur in older age too. It is firm, rubbery and non-tender mobile lymph, and there is no lymphadenopathy. Then what are the differential diagnoses? Fat necrosis, breast hematoma and duct ectasia are present. Then what are the investigations that are done for the case of fibroadenoma? These are history taking, physical examination, mammography, ultrasound of breast, MRI, biopsy for histopathology, and ultrasound guided biopsy. Okay. What are the treatment options for the fibroadenoma? These are enucleation or wide local incision, then lumpectomy, surgical removal of discrete portion or lump of breast, then mastectomy. For large and recurrent tumors, it is surgical removal of one or both breast. If the lump is too much large, then mastectomy is done. Okay, so we have discussed the fibroadenoma. What important points will be given in the fibroadenoma that so that we can diagnose the disease? It will be the lump will be present in the breast, and it will be mobile in nature, and it will be hard. There will be no discharge, and the size will be 3 centimeter, and there will be no enlarged lymph nodes. What are the clinical features? It is common in young age, and it is firm, rubbery, and non-tender and mobile lump, and there is no lymphadenopathy. What differential diagnosis can be made? These are fat necrosis, breast hematoma, or duct ectasia. What investigations will we do? We will do the history, physical examination, mammography, ultrasound of breast, MRI, biopsy for histopathology, ultrasound guided ultrasound guided biopsy. And the treatment options are enucleation or wide local incision or lumpectomy. Or if these measures fail, then we will do the mastectomy. Now coming towards the breast abscess, we are having a scenario that write a short note on breast abscess. Okay, also known as mastitis. Breast abscess is also known as mastitis. Breast abscess is sequel of bacterial mastitis. Mastitis is inflammation of the breast tissue. Now what are the causes? We have lactational causes and non-lactational causes. In lactational causes, we have Staphylococcus aureus. In non-lactational causes, we have middle-aged female who smokes Streptococcus. Middle-aged female who smoke and having Streptococcus and eros periareolar or periductal inflammation and peripheral non-leaking, non-lactating breast. So diabetes, steroids, and rheumatoid arthritis are present. So we are having these lactational and non-lactational causes. Then what are the clinical features of the breast abscess? These are pain, redness, swelling, fluctuation is a late sign. Okay, pain is present in the breast, and redness is present, swelling is present, and fluctuation may be present, but it is a late sign. Then what are the treatment options? We are having the supportive measures and the specific measures. In supportive measures, breast support milk should be expressed. Okay, antipyretics and analgesics are given, and hot fermentation is done. In specific measures, we will do the medical and surgical treatment. In medical, in cellulitic phase, antibiotics, local heat, and analgesia are given. The specific antibiotics that we will use are coamoxiclav and flucloxacillin. In surgical options, when abscess develop, drain or aspirate, then method give circumarular incision, better cosmetic result, and EMLA or analgesic applied 30 minutes before surgery, and then incisional drainage of pus is done. What are the complications? Recurrence can occur, infections can occur, and delay in healing, and the formation of antibioma. Okay, so what we have discussed, breast abscess, we have to write note on it. Breast abscess is also known as mastitis, and it is a sequelae of bacterial mastitis. Mastitis is an inflammation of the breast tissue. Then we have two broad classes, that is lactational and non-lactational. In lactational, we have Staphylococcus aureus. In non-lactational, the common features are middle-aged female who smokes, Streptococcus and eros periareolar, there is periductal inflammation or peripheral non-lactating breast. If there is non-lactating breast, and diabetes, steroids, and rheumatoid arthritis are the most common causes of breast abscess. What are the clinical features that the patient present with? The patient will be having pain, redness, swelling, fluctuation is also present, but it is a late sign. Then what treatment options will be provided? First, we will give the supportive measures and then the specific measures. In supportive measure, breast support is given and milk should be expressed. Then antipyretics, analgesics, and hot fermentation is applied. In specific measures, we are having medical measures and surgical measures. Medical and surgical treatment is provided. In medical, cellulitic phase, antibiotic, local heat, and analgesia is given. In antibiotics, coamoxiclav and flucloxacillin is given. In surgical, when abscess develop, drain, or aspirate, then the method is give circumarular incision, better cosmetic result. EMLA or analgesic is applied 30 minutes before surgery, and incisional drainage of pus is done. Now, what are the complications that a patient can develop? Recurrence can occur, infections can occur, delay in healing can occur, and formation of antibioma can occur. Okay, now coming towards our next topic, that is mastalgia. Okay, in mastalgia, we are having a scenario that there is a 24-year full month history of intermittent pain and tenderness with the right breast, Pain was before periods and spontaneously resolved shortly afterwards. Examination is unremarkable. Now we are having two types of mastalgia, that is true mastalgia and false mastalgia. True mastalgia occur in the breast and false mastalgia occur from the chest. Okay, now discussing true mastalgia, we are having cyclical pain and non-cyclical pain. The cyclical pain occur in 2/3 of the patients, while non-cyclical pain occur in the 1/3 of the patients. What is the cyclical pain? Cyclical pain affect our outer quadrant of the breast more glandular hair. Pain occurs 3 to 7 days before menses and improves at onset of menses. Now, what are the causes of cyclical pain? Due to exaggerated response to normal hormonal changes that occur during menstrual cycle associated with swelling and increased nodularity of breast. In non-cyclical pain, we are having non-related to menses and it is less responsive to drug therapy. Now, what is the treatment options for the breast mastalgia? The first one is we have to reassure the patient after significant disease, that is cancer. Then evening primrose oil is prescribed. Mainstay of treatment contain gamma-linolenic acid. It is fatty acid modulated hormone receptor interaction in breast tissues. Results appear in 4 months. Cyclical 58% results, and in non-cyclical there is 38% result. Then we will give the breast support, that is firm bra at day and soft bra at night is used. Then danazole is given. It is anti-estrogenic effect used in severe men. Other drugs are bromocriptine, tamoxifen, and testosterone and gasoline. Okay, how you have to manage the patient? First, take the history and do the examination, then investigate the patient. Then mammography is done for cyclical or non-cyclical. Then reassure the patient, and chest wall pain if severe, then NSAIDs are given. If not severe, then simple analgesics are given and treatment is given, and then counsel the patient. Okay, so what we have discussed in the mastalgia. Mastalgia is the patient we are having with clinical features are that there is 4-month history of intermittent pain and tenderness with right breast, and the pain was before periods and spontaneously resolved shortly afterwards. And the examination is unremarkable. So we have two kinds of mastalgia, that is true mastalgia and fast mastalgia. In true mastalgia is from the breast and fast mastalgia is from the chest. True mastalgia, we have cyclical pain and non-cyclical pain. Cyclical pain occur in 2/3 of the patients, while non-cyclical pain occur in 1/3 of the patients. Then we discuss a cyclical pain and the causes, then the non-cyclical pain, and then what are the treatment options. First, we have to reassure the patient. Evening primrose oil is used, breast support is given, danazole is used, and other drugs are used. The management options usually include the history, examination, the investigation, the reassurance of the patient, and the treatment of the pain, and then the counseling. Now, coming towards the breast carcinoma. This is very important topic in the breast, and this is very commonly and frequently asked, so we will learn this in detail. The scenario is that we are having a 50-year-old patient who is having 5 cm non-tender lump in upper outer quadrant of right breast for 2 months, also has firm lumps in right axilla. Now, what is the diagnosis? What is the investigation? What is the assessment? What are the complications of surgery? What is the treatment option? And what is the role of chemotherapy and radiotherapy? Okay, if we focus at the age, it is 50-year-old patient. So the carcinoma of breast is common in the age 40 to 50 years, and the diameter is 5 cm and non-tender lump in the upper outer quadrant of the right breast for 2 months, also has firm lumps in right axilla. Other lumps are also present. Okay, so what are the clinical features that are present? That is, the lump is commonly 3 to 5 cm and there is no discharge and mobile and not attached to the skin. It is tender slightly, and lumps in axilla are also present, and family history may be present. Okay, these are the diagnostic points for the carcinoma of breast. What are the differential diagnosis it have? It may be fibrocystic changes or antibioma or fibroadenoma. Okay, now breast tumor, most common cause of death in female. Breast tumors are very common in female and are the most common cause of death. Now it is at the age it is decreased at 20s and increase with age at 90. Greater than 20% of ladies have breast carcinoma. If the family history is present then in the first degree relatives, then there is high risk of carcinoma of breast, 0.5% in male and more in female. Hormonal exposure to estrogen and progesterone increase the risk. Long menstrual cycle, that is early menarche and late menopause, increase the risk. Late first pregnancy after age of 30 years increase the risk. Pregnancy protective, breastfeeding protective, OCPs increase the risk, HRT increase the risk. Okay, if breast pregnancy occur and breastfeeding occur, then it is protective. This decrease the chance of the breast carcinoma. The chance increase in OCPs and increase in the hormonotherapy. In the diet, that is alcohol intake, increase its risk, and the radiation exposure also increase the risk of carcinoma of breast. Now we are having the classification which is invasive and non-invasive breast carcinoma. In invasive carcinoma, we are having ductal carcinoma in situ and lobular carcinoma in situ. In invasive, we are having invasive ductal carcinoma more than 80%, invasive lobular carcinoma 15%, medullary carcinoma, colloid carcinoma, inflammatory carcinoma, and Paget's nipple disease. These are the common classifications of the breast carcinoma. Now the spread is local, lymphatic, and hematogenous. In lymphatic, it is axillary, internal mammary, supraclavicular, contralateral. In hematogenous, its spread is through bone, through liver, lungs, and brain. Now coming towards the clinical features. In clinical features, there will be the signs of that lump will be present, nipple retraction is present, blood stain discharge is present, axillary lymphadenopathy is present, and bone metastasis is present. What investigation or assessment we will do? First of all, we will do the triple assessment, that is history, examination, investigation. First of all, we will take the history of the patient and examination is done, then imaging is done. In imaging, ultrasound if patient in young, and mammography if it is present above the 35 years of age, then biopsy for histopathology is taken, that is true cut or incisional biopsy. Then investigations are done for the diagnosis of malignancy, that is fine needle aspiration, core cut or true cut needle biopsy when FNAC is non-occlusive or incisional biopsy. Then local extent of disease is found by through mammography, ultrasound, and MRI. The important receptors in management of breast carcinoma are estrogen receptors, progesterone, and HER2 new receptors. Then we will do the check for the lymph node involvement. Clinical judgment is done and sentinel lymph node biopsy is checked. Then systemic spread is done. For this, pulmonary metastasis is checked. X-ray or CT chest is done. Liver ultrasound or CT abdomen is done. Brain or CT scan is done. Bone radioisotope bone and bone scans are done. Now we will discuss the staging of carcinoma. These are TNM tumor staging, TNM node staging, and TNM metastatic staging. This is very important. We should know the staging of the breast carcinoma. First of all, we are having tumor in situ, that is carcinoma in situ. Then T1, the primary tumor is less than 2 cm. At T2, the tumor is 2 to 5 cm. At T3, it is greater than 5 cm. At T4, involving chest wall or skin extensions. Now the TNM node staging, N0 is no lymph node involved, N1 is palpable mobile involved ipsilateral axillary node, N2 is fixed involved ipsilateral axillary node, and N3 is ipsilateral internal mammary node. Okay, now M0 is no distant metastasis and M1 is distant metastasis. So what is the UICC staging? Stage 0. At stage 0, we are having tumor in situ, no lymph node involvement, and no metastasis. At stage 1, we have primary tumor that is less than 2 cm and no lymph nodes and no metastasis. At stage 2, we are having a primary tumor and lymph node, palpable mobile involved ipsilateral axillary lymph node and no metastasis. At stage 4, we are having tumor of any stage, that is 2, 3, or 4, and lymph node, any involvement of any lymph node involvement, and metastasis is also present. This is the UICC staging. Now we are having the another staging system, that is Manchester staging. We are having at stage 1 a mobile limb in breast, no palpable axillary lymph node. At stage 2 a mobile limb in the breast, palpable mobile axillary lymph node. At stage 3 we are having fixed lump in breast with or without palpable mobile or fixed axillary node. At stage 4 we are having distant metastasis. So this was the staging of the breast carcinoma. Now we are having the management or treatment options for the breast carcinoma. These are, first we will take the history, then we will do the examination for the morphology of the mass or systemic spread or lymphadenopathy, then we will do the investigations. What are the treatment options? These are depends upon the stage of the disease. Ductal carcinoma in situ, then partial mastectomy is done, adjuvant tamoxifen is given, and aromatase inhibitors are given. If the lobular carcinoma in situ is present, then we will do the lifelong surveillance. The prophylactic tamoxifen therapy or bilateral mastectomy is done. Okay, the surgical options for stage 1 and 2 are, first one is the breast conserving surgery, that is resection of the primary breast cancer. The wide local incision or leucectomy or quadrectomy is done. Then on the second number we are having the mastectomy for large, that is greater than 4 cm tumor. Simple mastectomy, extended simple mastectomy, modified radical mastectomy, and Halsted radical mastectomy. These are done as a surgical procedure for the management of the breast carcinoma. Breast surgery is done. Now for non-surgical, for stage 3 and 4, chemotherapy for stage 1 and 2 is greater than 1 cm. Hormonal therapy, that is tamoxifen and anastrozole, is provided. Radiotherapy is provided, and immunotherapy is provided. Now what are the complications? We are having the complications of anesthesia. These are respiratory depression, arrhythmia, asphyxia, etc. In op complications, we are having hypotension, bradycardia, aspiration, and recurrence. In post-op complications, we are having hematoma, seroma, wound infection, flap necrosis, nerve injuries, and edema. Nottingham prognostic index. It is used to determine prognosis following surgery for breast cancer. How we will calculate formula? NPI is 0.2 into S plus N plus G, where S is the size of the lesion in centimeters, N is the lymph node involvement, that is 1 or 1 to 3 is 2. If 3 lymph nodes are involved, then the 0.3 is added. G is the grade of the tumor. If grade 1, then it is 1 point. If it is grade 2, then 2 points, and if it is grade 3, then 3 points. Interpretation 2 to 2.4. If 2 to 2.4 points, then 93% of survival rate. If 2.45 to 3.54 points, then 85% survival rate. If 3.5 to 5.4, then 70%, and if 5.4, then 50%. So we have discussed the most important topics in breast, and the last that we discuss is the carcinoma of breast, which is the most common and important topic. In the scenario, we will be having the clinical features of 3 to 5 centimeter. There will be no discharge, there will be mobile and no attachment to the skin. It will be tender slightly, and lumps will be present in the axilla. The family history may also be present. The causes include the age, family history, the gender, hormonal, long menstrual cycles, the late first pregnancy, breastfeeding, OCPs, HRT, diet, and radiation exposure. Now we have classification of the breast carcinoma. It is non-invasive and invasive. In non-invasive, we are having ductal carcinoma in situ and lobular carcinoma in situ. While in invasive, we are having invasive ductal carcinoma more than 80%, invasive lobular carcinoma 15%, medullary carcinoma, colloid carcinoma, inflammatory carcinoma, and Paget's nipple disease. In spread, we are having the local spread, the lymphatic spread, and the hematogenous spread. The lymphatic spread involves the axillary spread, the memory spread, supraclavicular, and contralateral spread. In hematogenous, we are having the bone spread, the liver spread, the lung spread, and the brain spread. In clinical features, we are having lump, nipple retraction, blood stain discharge, axillary lymphadenopathy, and bone metastasis. In investigation, assessment is done, that is triple assessment, and history and examination is taken. Imaging is done, biopsy for histopathology is taken. In investigation, first the diagnosis of malignancy is done, then local extent of the disease is found, then lymph node involvement is found, and then the systemic spread is found. Then the staging of carcinoma, we have TNM tumor staging, then the UICC staging, and then the Manchester staging, in which we have stage 1, 2, 3, and 4. Then evaluation of the axilla is done. Okay, we will discuss this in the evaluation of the axilla. 5 nodes in axilla described under lymphatic drainage of breast. Very often central group of nodes, pectoral nodes are enlarged, difficult to feel apical group of nodes. If axillary nodes are hard with or without flexibility, there are significant soft to form nodes need to be malignant but can be due to secondary infection because of unjetting or ulcerating growth. Presence of supraclavicular lymph nodes doesn't indicate metastatic disease. Now, what are the management or treatment options? History is taken, examination for morphology of mass, systemic spread or lymphadenopathy, investigation is done. What are the treatment options? Depends upon the stage of the disease. Ductal carcinoma in situ, partial mastectomy is done, adjuvant tamoxifen and aromatase inhibitors are done. Lobular carcinoma in situ, lifelong surveillance, prophylactic tamoxifen therapy or bilateral total mastectomy. Now, what are the treatment options? These are surgical for first stage and second stage. Breast conserving surgery is done, mastectomy is done, and radical breast surgery is done. What are the non-surgical options? These are for stage 3 and 4: chemotherapy, hormonal therapy, radiotherapy, and immunotherapy. These are non-surgical techniques. What are the complications of breast carcinoma? These are anesthesia, in-op complications, and post-op complications. What is nothing harm prognostic index, and what are the calculation formula? It is 0.2 multiplied by S plus N plus G, where S is the size, N is number of lymph nodes, and G is the grade of tumor. Here we have in our discussion of breast unit. In the next section, we will discussing the thyroid topic. Thank you.